examining the pharynx, it is important to keep certain anatomical relationships clearly in mind. This sagittal view of the pharynx depicts several important landmarks for this examination. The anatomical boundaries of the nasal pharynx includes the phrenoid sinus superiorly, the choana anteriorly, and the adenoidal pad posteriorly. The lateral boundaries include the torus tiberius, which defines the orifice of the tympanopharyngeal duct. The oropharynx includes the posterior tongue and the vallecula, which lies immediately superior to the epiglottis. The lingular tonsil tissue and the circumvallate papillae are usually not appreciated on routine exam. The soft palate and the uvula are important in determining the quality of phonation, proper swallowing function, and equally important factors in sleep apnea. The hypopharynx includes the glottic structures and the larynx. We will examine these areas in detail. Now, proceeding into the pharynx by directing the fibroscope along the soft palate, the pharynx appears as an ovoid passage lined by a smooth mucosal surface. The uvula, moving here at 6 o'clock, and the soft palate define the anterior pharyngeal wall. The posterior wall is surrounded by pharyngeal constrictor muscles. The deep structures of importance include vascular channels like the major branches of the carotid artery and the vertebral bodies, also the posterior margin of the parotid glands. The epiglottis is seen here in the distance. The tissue seen here is the lingular tonsil. We'll look at it a little closer. The posterior tongue is found immediately anterior to the epiglottis. The lymphoid tissue seen here is the lingular tonsil. Sometimes pharyngeal lymph tissue can be markedly hypertrophied, as seen here with this adenoid pad in a patient complaining of something obstructing her throat. She has previously undergone adenoidectomy. Note the lymphoid pillars extending well into the oropharynx and the cobblestoning of the posterior pharyngeal wall. The lingular tonsils come into view, and they are huge. They prevent visualization of the epiglottis. One can appreciate the patient's dysphagia complaint as she is attempting to swallow her lingular tonsils. Previously, otolaryngologists would have feared excessive bleeding from surgical excision of these tonsils. With the advent of laser surgery, this is no longer a major concern. In another patient, note the pulsation in the right lateral pharyngeal wall. This finding was unilateral and could represent a carotid aneurysm. Spasm of the constrictor muscles of the pharynx can lead to a dramatic reduction in caliber of the pharynx, as seen in this exam done after provocation challenge with workplace chemicals. This patient was complaining of marked tightness of the throat and shortness of breath from exposure to carbonless carbon paper and fumes from a copy machine. A midline protrusion of the posterior pharyngeal wall immediately opposite the uvula can represent a neurogenic tumor such as a chordoma. As seen on cervical neck films, it is identified as an osteophyte from the vertebral body. Before examining the larynx, let's return to the oropharynx and the posterior tongue. As we can appreciate from this sagittal drawing, structures not readily inspected on routine examination of the throat include the structures of the posterior tongue, Now we can take a closer look at taste buds or the circumvallate papillae, the lingular tonsils we have already discussed, and the recessed space known as the vallecula, located anterior and superior to the epiglottis. Then we will address the hypopharynx, the glottic surface of the epiglottis, and the larynx. The tongue is immediately anterior to the epiglottis. Here are distinct circumvallate papillae with the epiglottis in the background. Here is a mucocele on the lateral posterior tongue. This cystic vascular erosion of a circumvallate papillae requires further investigation, as does this fibrous tumor immediately lateral to the epiglottis on the left posterior surface of the tongue. Candida infection can be identified but must be distinguished from normal prism-like iridescence of spicular structures of the posterior tongue. Now, proceeding into the hypopharynx, we first identify the epiglottis, the trachea, the arytenoids, the false vocal cords, the true vocal cords, the petiole of the epiglottis, the left piriform sinus, and the superior cornu of the thyroid cartilage. The piriform sinus acts as a gutter which directs food and drink into the esophagus. Here is the right piriform sinus. In most examinations, one can readily inspect the anterior wall of the trachea. Phonation, saying the letter E, results in symmetrical movement of the glottic structures in this normal patient. You will note the small mucous bridge, which sometimes indicates edema. Pathology of the glottic structures can be dramatic. This non-smoking patient experienced a sudden onset of hoarseness 3 weeks prior to this examination. She had no previous history of hoarseness and suspected that worsening of mild allergic symptoms that she had experienced for many years might be responsible. She had noted symptoms compatible with a mild respiratory infection at the time of the onset of her hoarseness. Notice how the left true and false vocal cord does not move with phonation or respiration. The right vocal cord is uninvolved. The differential considerations here include involvement of the left recurrent laryngeal nerve secondary to carcinoma of the lung with mediastinal metastasis. Usually, an oat cell carcinoma would be considered at the patient's age of 40 years. Thyroid cancer would also be a consideration. This finding gave an entirely different perspective to the clinician and dictated several diagnostic studies, including x-rays, which ordinarily would not have been considered in the face of a 3-week history of hoarseness that could clinically be attributed to a URI. Here we are looking at a 16-year-old boy who presented with a fairly routine story for generalized urticaria with mild edema of the soft palate. Note the marked edema of the right arytenoid and para-arytenoid structures in this youngster. This fairly routine medical problem became a potential medical emergency. This patient presented with complaints of laryngeal irritation from workplace exposure to solder fumes. Identification of this sessile polypoidal stalk from a previous papilloma led to the correct interpretation of a rather bizarre neuromuscular complaint. It allowed for successful psychological intervention. This gentleman complained of chronic hoarseness and exercise shortness of breath associated with asthma. He had a previous history of classical seasonal worsening of asthma and hay fever symptoms, including laryngeal irritation and associated hoarseness. Exercise symptoms were remarkably worsened over the 1 year prior to this examination. Huge laryngoceles are identified. Infection in these air spaces could be life-threatening. Corrective surgery resulted in loss of exercise asthma and a marked improvement in overall voice quality. He continues to have seasonal hay fever, but asthma symptoms are markedly improved. We are sure that the implications for clinicians are obvious from these examinations. We would note that one other very practical use of the fiber optoscope in emergency situations includes the direct visualization of the larynx for placement of an endotracheal tube where difficult intubation might be encountered. Perhaps we should also include the diagnosis of epiglottitis. The fiber optoscope can be placed into the posterior pharynx within seconds. This would allow for direct visualization of the laryngeal structures and remove any ambiguity that might exist in attempting to decide on the need for an immediate intubation or tracheostomy. It is our conclusion that fiber optoscopic examination of the upper airway is a remarkable diagnostic tool that can be easily and inexpensively employed by clinicians. We feel it profoundly broadens diagnostic perspectives and gives a new dimension to interpretation of patient complaints. We're of the opinion that examination of the upper airway with the fiber optoscope should become a part of the routine examination and investigation of pharyngeal and laryngeal complaints. We wish to thank the Olympus Corporation for their support in the production of this educational tape.